Hi, I'm Michaela V. I am a CLS second year junior, and I chose this program because I have always loved labs and science experiments. And I went on a tour on Blue and Gold Day with my mom, and I discovered the lab, and I just fell in love with the atmosphere and the fact that I'm an introvert and I can work just in the lab and do my thing and do the things I love to do, which is lab experiments and working with lab equipment. So I thought this was a perfect program for me, and I changed over my major quickly from kinesiology to be in this field. And I'm super excited to still be in here, be in this program, be with these people, and hope I can continue. And let's start with the review. So the class I'm going to go over today is Hematology 2, which compass a lot of information. So I'm just gonna do a short review on the main things that we learned and studied this semester. I'm not gonna go too in depth because we could be here for hours, and I don't want that. I don't think you want that. So let's go ahead and start. Okay, so at the beginning of the semester, we talked about hereditary conditions, which mainly we're going to see in neutrophils. So we're going to start with looking at aldehyde, which is large azophilic granules that we can see within the neutrophils, and these can be hard to differentiate with toxic granules, but if you look closely and you consider the patient, then we can figure out that it is in fact aldehyde. Since I have my little notes here, I have some photos that I'll be trying to present if my camera can actually show the photos. So I have marked off aldehyde, so we are going to be able to see here. So see how the granules are looking like bigger, and like I said, it's gonna be harder to differentiate from toxic granules, but we could do it. I believe in this. So moving on, we have Chiriac Higashis, which is large liposomes fusions of primary granules. So this one is also going to be a little bit harder to differentiate between toxic granules and aldehydes, but they have a larger, more looking appearance, which we're going to be seeing with the photo that I will be showing. So you see how they have like larger granule looking? So this is what we're going to be seeing in our neutrophils, the larger granules. So moving on, we have meheglin, which includes large platelets and inclusions that's going to look like Dowell bodies, which is like a segment of light blue that's going to look like on the peripheral smear that we're going to be used to analyze to get to meheglins. So I also have a meheglins that we can look at. So right here it's pointing to the Dowell body inclusions. Look like that. It's going to be a lighter blue, and then we're going to be seeing more larger platelets, which we're going to also be seeing in coag disorder later in the video. So just keep in mind about the inclusions, about what we're going to be seeing, and yes. Okay, so moving on to Pelger-Hewitt, which is a hypersegmented neutrophil. So to me, it's gonna look like kind of like binoculars in a way. It's gonna be like connected, so it's bilobed. It's gonna look like bilobed, and to classify it as Pelger-Hewitt, it's gonna be more of these cells looking like in the peripheral smear. If we see one or two, then we can't really classify it as Pelger-Hewitt unless we see more. So right here we have Pelger-Hewitt. This is what's gonna look like with connecting with the two bilobe. See how it's more like in the peripheral smear? That's what we're gonna be using to analyze, differentiate with Pelger-Hewitt, unless of a normal blood smear. So moving on, we have proliferative neoplasms, which is clonal disorder characterized by increase of red blood cells, white blood cells, and or platelets. So we're going to be looking at first primary fibrosis, which includes bone marrow fibrosis. So this is when there's an increase in bone scarring. So because there's an increase in it's gonna usually cause these like conditions are gonna include in a large spleen. So because of that, when we're gonna be trying to check the bone marrow, it's gonna usually get a dry tab. So that is what we're gonna be looking at, including some other things, but I'm not gonna go too in depth. So moving on, we have essential thrombocytopenia, which is an increase in megakaryocytes and platelets. Megakaryocytes is a precursor for platelets, so that is going to help us differentiate, but it is going to be harder to think of from other thrombocytopenias and not thrombocytopenia, because that's a decrease. Thrombocytoemia. Thrombocythemia. Okay, which is the increase. Okay, so we're gonna see an increase in that since these are in the proliferative. So moving on, we have chronic myelogenous leukemia, CML, which is also we're going to be looking at later in other CMLs, but we're going to talk about it here because this is an increase of white blood cell precursors starting from blasts, moving on to mature neutrophils. So with this, we're going to see the Philadelphia chromosome, which is a translocation from the 9 to the 22, which is going to cause a fusion in the BCR and the ABL. Sorry, just making sure I'm getting the right things right. Okay, so that we're going to be seeing the fusion gene take place in the Philadelphia chromosome, and to help us also with this differentiation, since we also see an increase in white blood cells in infections, we're going to be using the LAP, which is the leukocyte alkaline phosphate test. So an increase in LAP indicates an infection, which is what we can associate with leukemioid reaction, and a decrease in LAP is what we're going to be seeing in our CML, our chronic myelogenous leukemia. So that is going to be a key to help us differentiate and a key to remember. So moving on, we have sorry, that's my sister. Okay, so moving on, we have our polycythemia vera, which is an increase in red blood cells, but yet again, we can also see an increase blood cells and other things. So what's going to help us in know that it's polycythemia vera is the JAK2, which is the genus kinase 2 mutation. So that is very important to associate polycythemia vera with JAK2. So going on to another topic, we have myelodysplastic syndromes. So what we're going to be seeing here, so I'm just making sure I'm getting everything right. Okay, so what we have here is refractory anemias based off classification. So we have refractory anemia, which is less than 5% of blasts. We have refractory anemia with ring sideroblasts, which we're going to be seeing with our Prussian stain. Since we can't see sideroblasts with our right stain, we're going to be using the Prussian stain. Okay, and then we have the refractory anemia with excess blast, which is going to be more than 5% since we already have the other refractory anemia with less percent. So what we're going to be seeing usually is within 5 to 20% of blast in the excess blast. Hey, that's my mother. So moving on, it's a little distracting, but it's okay. So moving on to our acute myeloid leukemias, we are actually going to be like looking at the WHO classifications, because these are, well, there's two classifications that we can use. We can use the WHO, we can use the FAB. What I'm going to be focusing on today is the WHO, which includes the M0, M1, M2, M3, M4, M5, M6, and 7. And let it be known that some of these M, like, M classifications, if you want to say, have different subtypes within. I'm not going to be going over specifically in this video because it's a lot of information, but I'm just going to focus on the main ones that in the line. So for M0, we have myeloblast without differentiation. So this is without us knowing whether it's gonna go so it's not gonna be pro. We don't really know. Essentially. So moving on to our M1, myeloblast with minimum maturation is what they say. It's, yeah. Then M2, myeloblast with maturation, which is, now we know for sure that is going to be in this classification. And M3 is where we're going to be seeing promyelocyte. And this we spent a lot of time on, specifically in class. We're going to be seeing with our translocation 15 to 7 and our rods, which is going to help us differentiate this as an M3. Our rods are little red like rods that we're going to be seeing within our promyelocytes. That's how it's going to be differentiate. So our M4 is our myeloblast and monoblast. So now we're like dipping into the monoblast category. And our M5 is our monoblast, but it's just the monoblast. So yes. M6 is our erythrocytic series, which is where we're going to be seeing our precursors for our erythrocytes, our red blood cells. And so M7 is our megakaryocyte series, where we're going to be seeing our premature platelets. Since megakaryocytes are premature platelets, we're going to be seeing an effect with those. And yes, so we're going to be moving on to our lymphoproliferative neoplasms, where we're going to be looking at our acute lymphocytic leukemias. So we're going to also stay with the classification of L1, L2, L3. So our L1, we're going to be seeing our smaller lymphoblast, and it's going to be a lot of the smaller lymphoblast taking place. Our M2s, it's going to be a larger lymphoblast taking place, and you will be able to differentiate based off the size, usually depending on what we see within the peripheral blood smear. Our L3s are, to me, the easiest to differentiate because they are a specific type of cell that we're going to be looking at. These are going to be usually our Burkitt cells. So these are going to be our lymphocytes, lymphoblasts with the vacuoles within. And those are easy to differentiate because there's going to be a lot of them that have these vacuoles going to be like together. And so that is what we're going to be looking for. Moving on, we have our hairy cell leukemia, which we have projections of cytoplasmic, like coming off of the lymphocyte. So it's going to be coming off looking like a hairy cell in a sense. So for this, we're going to be using our TRAP, which is our titrate resistant acid phosphatase, and it's going to be TRAP positive. Using the little hint from class, TRAP the hairy beast, TRAP positive, hairy cell leukemia. Okay, and so moving on, we have our plasma cell neoplasms. So starting with our multiple lymphoma, this is going to be easier to tell in our peripheral blood smear also because we're going to see a lot of Rolex taking place. Rolex is the stacking of red blood cells, and we're going to be seeing a lot of Rolex taking place. So if we see the Rolex, we're going to think in our head, oh, this could be multiple myeloma. And so on our serum electrophoresis, we're going to see an increased monoclonal spike in IgGs. since this is where it's going to be taking most place. And then we're also going to be seeing multiple bone lesions taking place, which we can associate with bone pain because it's bone lesions taking place in the bone. So, makes sense. Okay, so we're also gonna see urinary excretions of Binge-Jones proteins, which is light chains that we're gonna be seeing in the urine. So that's gonna also help us differentiate and come up with multiple myeloma. So moving on, we have Waldenstrom's macroglobulinemia. Sorry, these names are a little harder to say sometimes, but yes. So for that, we're going to be looking at our serum electrophoresis, and we're going to be seeing a spike in the IgMs because these are larger cells. They're going to be heavier, so that's why we're going to be seeing them in IgMs, monoclonal spike. So also because of their larger area, if you want to call it, for the IgMs, we're going to be seeing an increased serum viscosity. That is also another hint on why we're going to be able to classify this as the Waldenström macroglobulinemia. Okay, so moving on, I'm going to talk about the platelets. I'm going to be talking about the platelets, specifically coagulation. And we can see coagulation come in effect with blood banking also. Since I know some of the labs here have coagulation in the blood bank area, we can see the connection of blood bank and hematology, which hematology is connected to a lot of different areas and departments within the laboratory. One of the ones I noticed particularly was the blood bank with the coagulation. Since we are talking about coagulation in hematology too, I have a whole section, whole notes that we're gonna not technically go over because I have a lot of notes, but we're gonna mainly focus on the coagulation cascade, which is this. Okay, so moving this out of the way, we're gonna see the coagulation of forming a clot with mainly 3 steps. Okay, that's the main gist. It's 3 steps that we're going to be seeing, which is adhesion, activation, aggregation. Okay, so that's what we're going to be seeing mainly with our thrombosis, clot forming. But going more in depth, we have a whole cascade on which makes these clots. So we have technically 3 pathways. We have intrinsic, extrinsic, and common. But both of the intrinsic and the extrinsic go within the common. So the common factor is the common system pathway. Okay, so going on to the in-depth of the pathways, we're going to be talking about the shortest one to me, which is the extrinsic. Okay, so for the extrinsic pathway, we're going to have tissue damage. So we're going to have tissue factor, and this is going to activate our factor 7 along with calcium. Calcium is going to be important within these cascades. Calcium is needed, calcium is wanted, calcium is within. Okay, so calcium is important. So our tissue factor is going to activate our factor 7. Factor 7 is going to then activate our 10, which is starting the common pathway. Since these are both going to go in the common pathway, I'm going to explain both, and then we'll move on to the common pathway to make a connection. Okay, so moving on to our intrinsic pathway, we have our activation with collagen. Collagen is what we're going to be seeing when we get like cut is going to be activating with the collagen exposure of our factor 12. So the activation of factor 12 is going to cause the activation of 11, and then we're going to cause the activation of 9, skipping over 10, which is easy to remember. So 12, 11, 9, 8. But we are going to see that factor 8 is technically a cofactor that's going to have help activate our factor 10. Okay, so it's a lot of information, but it's a pathway. It's going down. We're working with it. We're working with it. So going on to our common pathway, it's beginning of 10, which is technically the end of the intrinsic and the extrinsic pathways. So they both go down into factor 10. So this is where our common starts. So our common is going to be activated to, it depends on how you want to see this, but it's factor 2, which is prothrombin. Okay, so this is going to be transferring into the activation form of thrombin. With this activation, we are going to be needing calcium, which, if you know, is important, phospholipids, factor 5, which is a cofactor, and that's going to help us activate to thrombin. So going on, thrombin is going to activate fibrinogen to fibrin, which is our technical clot. Fibrin is like a clot. If you want to think of it that way, that's how I think of it usually. Thrombin is a clot, and to help stabilize, we have factor 13, which is our clot stabilizer. So with that, we have activation, we have our clot. So that is the coagulation cascade in the sense of just going down. Of course, it goes more into detail, but we're not going to go too far into detail. So as we see, a lot of things happening, a lot of things going to be moving with this, and yes, so with this, we have certain defects that we can have occurring. So I'm not going to go too in depth on the defects and the deficiencies that we can be seeing, but I will be going over some. Some of the important things to remember also is that we have vitamin K, which is very important. Vitamin K can be essential for certain factors that we're going to be seeing within our cascade and with in our fibrinolysis, which includes factor 2, factor 7, factor 9, and factor 10, along with our factor C and factor S. I believe it is. Yes. Okay. So we know our factor C and factor S is important because they help fibrinolysis, which is breakdown of clots, which factor S, am I saying that right? Sorry, just real quick. Okay, I'm back. Sorry, not factor. Protein C, protein S. Sorry. I remember CS. Okay, so protein S is a cofactor to help protein C. Protein C inactivates our cofactors 5 and 8, which is needed with the coagulation cascade to actually form the clots. So without those, we can't have the clot, which is why we have fibrinolysis. So that is important to remember. So that is important. That is also vitamin K dependent. So those are important to remember, especially when thinking about vitamin K deficiencies. Those will not be working since they are vitamin K um, dependent. So, moving on to specific disorders, we have hemophilia A, which is a problem with factor 8. We have hemophilia B, which is a factor with which is a problem with factor 9. We can also sometimes see hemophilia C, which is a problem with our factor 11. And we are commonly sometimes going to be seeing our von Willebrand's disease, which von Willebrand's helps with adhesion. So with that, we can be seeing a defect with the actual function of von Willebrand's, or we can be seeing a decrease in von Willebrand's. Both of those will be classified in our von Willebrand's disease category. But that is also remember that factor 8 like is like a buddy with von Willebrand's factor. So like a decrease in the effect problem of von Willebrand's will also affect factor 8. So that is important to remember. And so another like disorder that we're going to sometimes be seeing and sometimes like important to think about is Bernard-Soulier. This is the other one that I was saying to think about with the giant platelets, because we're going to be seeing giant platelets here. So with the Bernard-Soulier, we are going to be seeing an effect in our adhesion our adhesion molecules that are going to help us here. So Bernard-Soulier is going to be our genetic mutation of our glycoprotein 1B and A9. There you go. There you go. So 1B9. And we can also be seeing another adhesion problem with our so I'm seeing how to say it, with our gen our Grimmin Glassman, with our Glassman thromboasthenia. So this is going to be a mutation with our glycoprotein 2A3B. So that is that is reversed. Glycoprotein 2B3A. So that is going to be important to remember with our platelet disorders. So wrapping that up, that was a short little review on hematology 2. It's a lot of information, so it's important to remember details for certain diseases and disorders and what the peripheral blood smear is going to be looking like in certain tests, but it is possible to remember. So just keep studying. I definitely keep studying, and hoping me study will help me along with our pectoralship that is coming up next semester, because we are going to be working with actual live specimens coming from real life people. So it is important to keep all the information and the knowledge that we have gained through this semester to help us within our pectoralship, specifically in the hematology lab department. So when we going to be working, we're going to be looking at the peripheral blood smear. So that is important to know what certain disorders and characteristics are going to be look like for those, especially with the tests that we're going to be doing in that department. So everything is just important to remember for going into our rotations. I know this course has infected me by helping me remember all the important stuff to help me with pictorialship rotations, such as learning about the white blood cell and red blood cell disorders and the breakdowns of within, such as precursors for neutrophils, lymphocytes, and the disorders that are associated with them, and help the genetic mutations that are also seen within, and to just help get a better understanding going into the program. So, I'm just seeing what I have to make sure to go over. So, that is the main gist. And yes, so this is a very important department to know and remember. And yeah, I find this course intriguing, hard, but exciting to learn about, and hope to continue learning and hope to continue to develop my skills and the information that I gain through the course by reading the books and the textbooks and the keynotes, along with learning in real life at the vectorship rotations, and just continue to learn. And thank you for listening. If you made it this far in the video, thank you, and bye.